All right, let's talk about chapter 23, behavioral and psychiatric emergencies and suicide. So we'll talk about the psychiatric emergencies and what we're going to do for these people. All right. Patients may present with unexpected or dangerous behavior. These behaviors may result from stress, physical trauma or illness, drug and alcohol abuse, or psychiatric condition. But what is a behavior? The definition of a behavior would be a manner in which a person acts or performs. Behavioral emergency is defined as a behavior within a given situation that is unacceptable or intolerable to the patient, family, or community. So behavior is something somebody does. Behavioral emergency is when somebody does something that's unacceptable. Lashing out. People could be having hallucinations, things of that nature. That's what we consider a behavioral emergency. Okay, they may appear confused and have an altered mental status. The psychiatric conditions, there's a few here listed: anxiety and panic disorder, depression, bipolar, and schizophrenia. And there's a lot of different psychiatric conditions out there. If you're ever interested in looking at this stuff, you can look at the DSM manual, Diagnostics and Statistics manual that mental health professionals use to diagnose people. There is a lot of them. This is a very big book. This right here is just 4 big ones that we might see. So what are some physical causes of altered mental status? We talked about this in chapter 19, the diabetic section. But could be low blood sugar, which would be hypoglycemia, lack of oxygen, which would be hypoxia, stroke or inadequate blood to the brain, could be head trauma, mind-altering substances, or environmental temperature extremes. So real hot, real cold, that can cause some altered mental status. Some normal reactions to stressful situations, they produce emotions. So it's normal to stressful situations. We could see fear, grief, anger. We can see them all at the same time. We can see them rapidly change. All of us react a certain way to stressful situations. But what we're talking about here as far as behavioral emergencies go is when it's gotten to an extreme. So how do we care for patients with situational stress reactions? Well, we don't want to rush, right? Tell the patient we're there to help. Remain calm. Keep your emotions under control. Listen to the patient. Be honest. Stay alert for changes in behavior. So we're going to go there. We're going to identify ourselves. We're going to say, I'm Rob with the fire department. I'm here to help you. What's going on? Tell me what's going on. Okay. Remain calm. Keep your emotions under control. It's very important. These behavioral emergencies, we might not do a lot to treat these patients, but a lot of what we're going to do is provide that comforting care. So have a conversation with them, try to figure out what's going on and try to calm the person down a little bit, okay? There's a condition called acute psychosis that involves a severe break in the patient's ability to process information and interact with their environment. It's often associated with a cognitive disorder such as schizophrenia. Not always, but basically what happens is something snapped, and we've all seen people snap before where they get real angry and they get in an argument and that kind of stuff. Again, this is beyond that. This is something has really snapped and these people can become completely dissociated. Okay, certain symptoms these people might have would be hallucinations, delusions, catatonia, thought disorders. Ensure safety of the patient and responders is the most important thing. When we hear something related to behavioral emergencies, we want to be focused on scene safety. And we're going to talk about that quite a few times throughout this presentation. Emergency care for these emergencies. Assessment and care for the behavioral and psychiatric emergencies. Range of presentations. So they're going to be presenting who knows which way. Okay, we have to kind of be prepared to handle any of those. Withdrawn, not communicated. They could be talkative and agitated. Bizarre, threatening behavior or wish to harm themselves or others. All right. Key techniques. Identify yourself in your role. Like I said, my name's Rob. I'm with the fire department. What can I do for you? What's going on? Tell me what's going on. Speak slowly and clearly. Make good eye contact. Use good body language is another good one. Don't stand there with your arms crossed, looking angry and annoyed that you're there with this person, okay? Try to be caring, and they'll open up to you, okay? Listen to the patient. Don't be judgmental. Acknowledge the patient's feelings. Don't enter a patient's personal space. Stay at least 3 feet away from the patient. You're not only doing that to avoid agitating the patient by getting up too close to them, but you're also doing it to protect yourself. Okay, if this person snaps and they lash out at you, you want to have a little distance in between so you can protect yourself. Okay, be alert for changes in emotional status. They might be crying, they might be very upset right now, and it can turn very quickly into anger. Okay, and use restraint to prevent harm if necessary. And we'll talk about that a little bit more in detail further along. Here's just an example of what you can do if you're going to try to restrain a patient. These 4 EMTs here set up, they kind of surround the guy. They come up with a plan. They say, all right, this is what we're going to do. We're going to come in, we're going to grab the guy, we're going to set him on the stretcher. Okay, and we'll talk more in detail about the restraints here in a little bit. Patient assessment. Perform a careful scene size up. You're going to hear that several times throughout this presentation. Scene safety and size up is huge with this, okay? Identify yourself. Complete your primary assessment. We want to identify the life-threatening injuries that the person might have. That would be your ABCs, right? Complete that primary assessment. Perform as much of a detailed examination as possible. We're talking about secondary assessment. If we can get all those OPQRSTs and sample questions, great. If you can't, that's okay. That's our goal, is to get all that information, but sometimes you just can't, and you want to document as such. Okay, gather a thorough history if you can. Common signs and symptoms: panic or anxiety, unusual appearance, disordered clothing. Okay, this is just a list of things to look for that might be an indicator that the person's having some kind of behavioral emergency: violent or aggressive behavior, suicidal or self-destructive behavior. Okay, so what do we do for these people? Okay, again, be alert for personal safety. Treat any life-threatening problems. Consider medical or traumatic causes. So it might be that they fell down the stairs and they cracked their head and now they're not acting right. Okay, this could be a very serious condition. We need to get this person to the hospital quickly. All right, spend some time though. Okay, if they're willing to talk to you, sit there and have a conversation with them. Don't rush, unless you're considering the trauma, in which case it is kind of important to get the person to the hospital. This is a judgment call on your behalf. Okay, never play along with hallucinations, and consider involving friends or family. Sometimes that can help. If nothing else, reach out to the family or friends. Say, hey, what's going on with this guy? Is he acting normal? When did this start? You can get information from the friends or family. It also might not hurt to help have the family or friends help to calm the patient down, okay? And every situation is so dynamic and different. You're gonna, everyone's gonna be handled just a little bit differently. All right, real quick on suicide. Eighth leading cause of death at the time of this writing. It's the 3rd leading cause of death in an age group ranging from 15 to 24 years old. And I think that same group includes 40 plus. All right, so that's a pretty common reason for death. All right, how do we assess the patient for potential or attempted suicide? Okay, explore the following possibilities. Depression, high stress levels, recent emotional trauma. Did the person just have something traumatic happen to them? Did they just lose a loved one, husband, wife, that kind of stuff? What's their age group? Drug or alcohol abuse. Now, the age is probably the highest. The age numbers that they say here are probably the highest risk, but this can happen in any age. So you could have a 30-year-old that's not in this highest risk age group that does this. So don't just limit it to these numbers of 15 to 25 and 40 plus. All right. Explore the following possibilities: threats of suicide, suicide plan, previous attempts or threats, sudden improvement from depression. So these are some signs that the family might notice in the patient. We probably are not going to notice those things unless we're close to the patient personally. But we can ask the questions of the family members if we think it's necessary. Threats of suicide, have they threatened it now? Have they threatened it before? Do they have a plan? previous attempts. Have they done this before? And sometimes we will get those patients who we had to take in for cut wrists or whatever the case is. And then a couple weeks later, we're back and hear that same address. We're like, okay, well, what's going on here? Okay. Keep that in mind. Personal interaction is important. Do not argue, threaten, or indicate using force. Scene safety, again, you want to make sure that scene is safe, and treat any life-threatening problems. So this is a little redundant, and I know we're touching on the same point several times throughout this presentation. But again, personal interaction is important. We live in a world now where we text each other all the time. We don't even have phone calls, let alone face-to-face conversations, nearly as much as we used to. So this is where you need to brush up on your communication skills and your body language, okay? We don't focus a lot on that in this class, but it's something that's very important when you're operating as an EMT to actually be able to have a conversation with a person that's not through text. Okay, there's some think about it and critical questions throughout this presentation. Those are all in your book. I would encourage you to take a look at them, but we'll keep moving through the presentation. Okay, aggressive or hostile patients. Consider clues. What's the dispatch information? Are you being dispatched to a 74-year-old female with difficulty breathing, or are you going to a 38-year-old extreme hemorrhaging, lacerations on the wrist? Okay, you can kind of differentiate the two. Information from the family or bystanders. What's going on? Why'd you call? Why are we here? What's going on with this person? What's their stance or position in the room? What's their body language telling you? Because if they're standing there and they're breathing heavily and they're sweating and they look angry and their fists are balled up, okay, that's a hostile patient. Be careful. Ensure you have an escape route. Don't let that patient get between you and the door, okay? Even if you got to stand in the doorway or close to the doorway and talk to the patient from across the room because you're worried about your own safety, that's fine. You can do that. Don't threaten them. Stay alert for any weapons of any type. You know, occasionally we'll go into houses where people have their pistol on the table or a rifle in the corner, or a baseball bat, whatever it is. That's fine. People are allowed to have those things. But if you're there for a behavioral emergency, you should really be looking out for those things. If it's within arms, if you have a gun within arm's reach of the patient and they're extremely agitated, I'd probably pull out. I'd probably get out and wait for law enforcement to get there. And a note on law enforcement, by the way, 9 times out of 10, they're going to be dispatched to these calls with you. They're probably going to have you stage in your station until the scene is safe. So that gives us an extra layer of protection, but not always, because the people who are calling 911 for help don't always say certain things that will indicate to dispatcher, oh, we need to send the police with this. So occasionally those calls slip through and we'll show up on a scene where the scene is not very safe. And we need to be calling for law enforcement saying, hey, we need a police car here now. All right. Patient assessment. Ensure safety, calm the patient, perform a thorough assessment as much as you possibly can. Okay, and restrain the patient if necessary. We will talk about that here in a few minutes as far as our protocols go. Patient care, scene size up, request additional help if necessary. It gets back to the police. Do we need the police here? Do we need ALS here? What resources are available, and call them early to get them moving your direction. Seek advice from medical control if necessary. There's nothing wrong with you reaching out to medical control and calling the hospital and saying, hey, I got this, this, and this. I don't know what to do. Okay, these doctors are not judgy. They're not going to say, oh, that guy's an idiot. Okay, they're going to help you. That's their job. So don't be afraid to call for extra help if you need to talk to medical control. Okay, watch for sudden changes in behavior. Are they going from crying and upset and they're talking to you and then they start to turn and they're getting angry? Okay, watch out for those things. Reassess frequently. And again, consider restraint. We will talk about that. Right. So reasonable force and restraint. Reasonable force is defined as the force necessary to keep the patient from injuring themselves or others. Okay, we are not in the business of putting our hands on the patients as far as restraining. We're not going to go tackling somebody. That's not our job. That's law enforcement's job. All right, but you may find yourself in a situation where you need to defend yourself. You need to defend others. Now, this is not a basic, self-protection class. All right. This is just talking about how to protect yourself quickly, and hopefully you never need to do this, but it's not something we like to do, if that makes sense to you guys. Okay. But reasonable is determined by the patient size and strength. What's their behavior? What's their mental status? And available methods of restraint. So if a person's coming after you and they try to punch you, well, that doesn't mean that you can beat them up, okay? But you can absolutely defend yourself. And if you need to restrain a patient to defend yourself, that's okay. But we're getting into some real funky legality issues once we start getting into those things. So witnesses are very important. Documentation is very important. Things of that nature. But we try to diffuse the situation the best we can so we don't find ourselves in that situation. Okay, some systems don't allow for restraint without police or medical control orders. Never attempt to restrain without proper legal authority and sufficient assistance. So we do have a protocol in this region for soft restraints. Soft restraints are leather straps you can strap to your stretcher. Technically, by the book, we are allowed to restrain patients. However, any time that you are considering restraining a patient, you need to have law enforcement there. They are better at it than us. They have better equipment than us. They have better training than us as far as restraining people go. So if you have no other options, you can't get the cops there for some reason, we can do it. The key is that if you're going to restrain somebody in an ambulance, one, they have to be on their back. They have to be in the supine position, okay, so that you can maintain their airway. And two, you have to be able to remove those restraints. So that means that a police officer can't come into your ambulance, handcuff them to the stretcher, and then leave. That you have to have the ability to remove those restraints. So that cop has to ride with you if he's going to handcuff them to your stretcher. So keep these things in mind and take a look at what you have on your ambulances. They make some commercial devices, leather. I think they have some hard plastic ones with like cushioning on them. You can tie cravats. You can tie their wrists to the rails of the stretcher with cravats. Those are options. They're not ideal. It's an absolute worst case scenario. Okay. Excited delirium. Excited delirium is a condition where a person is extremely agitated or psychotic behavior during struggle, followed by cessation and struggling, respiratory arrest, and then death. Patient is often hyperthermic, which means high temperature, and shouting incoherently, and it's usually preceded by cocaine use. So this excited delirium is something that I don't believe I've ever actually seen in the street. And there's some good videos on YouTube. I would highly encourage you guys to take a quick look. They're short. Type into YouTube excited delirium, and you can get a little more information about the specifics. And what happens is these people get real hot. They're super agitated. They don't know what's going on. They strip all their clothes off and they go running down the street. And usually that's a police issue. So the cops get there, and this has happened a few times across the country, not around here. But what they'll do is they will strip their clothes off. They'll go running down the street because they're hot, they're agitated, they're psychotic. Cops will go up there and say, "What are you doing, naked guy?" And they'll cuff them, and they'll throw them in the back of the police car, and then they die. And that is not what we want to do. So the police have been trained to kind of identify this, saying, okay, this person's really out of it. We need EMS here. Get the paramedic there and do what they do, okay? Excited delirium is often linked to an improper restraint in a position where a patient can't expand. So what can happen here is, again, the cops throw the guy in the back of the police car, face down, whatever the case is, and they asphyxiate and they die, okay? So be aware, the person's extremely agitated and that kind of stuff, and they feel real warm to the touch. That could be excited delirium. We're not going to diagnose it, but keep in mind that this is a thing, and we definitely want to worry about their airway, and we want to get them to the hospital, okay? You can tell the ER that you suspect excited delirium. Okay, restraining a patient. Have adequate help. Plan your actions. Stay beyond the patient's reach until prepared, and act quickly. So what you can do is you kind of gather up your resources, your people, the police if they're there, if they need your help. Hopefully not, because we don't really get in the business of doing this, but we can. police, other members of your fire department that are there. You get in a group and you say, hey, all right, this is the plan. You go there, you go there, you go there, and we're all going to come in at the same time. We're all going to grab an appendage, and we're going to set this person on a stretcher, and we're going to strap them down. That is an option. Again, it's not ideal, but it is something that we can do. All right. One EMT talks to and calms the patient. This is just some ideas of ways you can handle the situation. Have the one person say, hey, man, calm down. All right, we're here to help you. Whatever it is you got to say. Okay. And then have the other people kind of come in and you all move in together and then grab them. Okay. Restraining patients. The EMT's responsibility for restraining patient's airway. So once you restrain that person, it is your responsibility to maintain their airway. Okay. If that person dies in your custody because you restrain them, you are in big trouble. Okay. So if they're restrained, make sure you're paying attention to what's going on with that patient. Okay. If they start spitting and they're real agitated and they're spitting everywhere, you can put a surgical mask on them to try to keep the spit down. Right now with the COVID stuff going on, we all should be wearing masks too, so that should help some protection there. Reassess frequently and document thoroughly. Document. Anytime you get into anything that's a little hairy, like, man, I got to put my hands on this guy, we got to restrain this guy, document very well, okay? Take your time to do it right. All right, transport to an appropriate facility. Not all hospitals are prepared to treat behavioral emergencies. Now, UPMC Chautauqua is, Hammett is, Brooks is. I don't know about Westfield. So those of you that are close to Westfield, or maybe that's your primary facility that you'll go to, take a look at that facility and see what they have. I think they probably do, but I don't really know about their resources too much, and I don't want to speak on that too much. So just be aware of whatever your primary facility is. Make sure that they're the right facility for you to go to, okay? Medical and legal considerations, consent. Refusals and restraints cause significant medical and legal risk. Laws typically allow providers to treat and transport patients against their will if it is a danger to themselves or others. All right, local protocol may require medical control or contact or police presence. So as far as consent goes for these patients, if they're really out of it, and a lot of times you can convince them to go, okay? But again, law enforcement being on scene, we don't have the ability as much as police officers to just take them to the hospital. We talked about consent early on in this class, but the police do. So if the police have determined this person is a danger to themselves or to a danger to other people, they can take them. They can force them to go to the hospital. So that's always an option. You can explain to the person, like, listen, you have to go to the hospital. I'm sorry. I know you don't want to, but this is what's best for you. So you can go with us or you can go with the police. And a lot of times, if they're coherent enough, they will choose to come with us. But there's nothing wrong with sending them with the police either if that's necessary. Okay. Sexual misconduct, behavioral patients, especially those requiring physical contact, such as restraint, sometimes accuse EMS providers. I've never heard of that happening in our area. It doesn't mean that it can't happen. We live in a very litigious society nowadays. So it's important to keep these things in mind. Try to have the same sex provider attend to the patient. So if you have a female patient that you restrain down, try to have another female patient be the provider. If nothing else, be in the back of the ambulance with you. Third-party witness present at all times on scene and during transport. So if you don't have that available to have the same sex provider attend, that's okay. That would be ideal, but we can't always do that. But if nothing else, another person needs to ride in the back of that ambulance with you, whether it be another member of your fire department, police officer, you got to have somebody back there with you just for your protection, okay? There's a video there on mechanical restraints. You can find those all on YouTube. So real quick chapter review. As an EMT, you will respond to many behavioral emergencies. Be sure to ensure your own safety before entering a scene where the person can be violent. Okay, we talked about that pretty in depth. Okay, your safety is number one. Considerable portion of the population has a diagnosable psychiatric condition. However, not all patients are violent. Like I told you guys, that DSM manual that the psychiatrists and psychologists and that use to diagnose these psychiatric conditions is huge. Probably a lot of us have psychiatric conditions that are diagnosable, That doesn't mean we're violent, okay? So don't get too concerned about that. If somebody has a psychiatric condition, it might not be a big deal, okay? Always consider patients acting in an unusual or bizarre fashion to be experiencing an altered mental status. This will help you avoid overlooking a medical or traumatic cause for the patient's problem. Again, we talked about altered mental status in chapter 19. There's lots of causes for altered mental status. It could be low blood sugar, it could be low oxygen, there could be trauma. Okay, there are some things. This person might not just have a psychiatric condition. This might be medical, and it might be trauma related. Because treatment of these patients usually requires long-term management, little medical intervention can be done in the acute situation. Basically meaning we're probably not going to do a lot for these patients as far as treatment. But the most important treatment that we can give is actually getting them to the hospital and getting them to the appropriate facility. Okay. Safety is the first priority. We beat that in you pretty good in this lesson. Psychiatric and behavioral emergencies are prevalent in our society. EMTs should treat themselves as they would any other potentially life-threatening disorder. Okay. Assessment of altered mental status should rule out physical causes first. Okay. The trauma, did they fall down the stairs and crack their head and now they're not acting right? That's probably the cause. Psychiatric and behavioral emergencies can present differently depending on the disorder. There are best practices EMTs employ in approaching, assessing, and treating such patients. They present differently. Okay. Follow local protocols when we're using our restraints. Again, if you're going to restrain somebody, try to do your best to get law enforcement. If some crazy thing is going on in the world and there's no law enforcement available and you're on scene, you got to do it. You can do it by our protocols. But please review the protocols and make sure that you understand everything that we're supposed to do. Okay, here's some questions to consider. They're all in your book. I'd like you guys to take a quick look at them and find the answers to them. And that's it for chapter 23. All right, we will continue in chapter 24 here in a little bit. I'll get that posted up to you guys, and I will see you